Next, Glenn Hirsch is joined by Dr. Jessica Mega, Associate Physician at the Brigham and Women's Hospital in Boston. They discuss how to pick an antiplatelet agent in acute coronary syndrome.
Thanks, Dr. Mega, for joining us today in the ACCEL studio.
It's great to be here.
We're going to be discussing what's sort of a confusing topic out there about picking antiplatelet agents in acute coronary syndromes these days. Dr. Mega, I was hoping, just to start us off, you could summarize some of the differences in the pharmacodynamics between clopidogrel, ticagrelor, and prasugrel.
Well, it's a great place to start. Certainly, clopidogrel has been used in thousands of patients who either have acute coronary syndromes or those undergoing percutaneous coronary intervention. And in general, we know that there's a reduction in hard cardiovascular endpoints, a reduction in cardiovascular death, myocardial infarction, and stroke. But the real question comes up is, are all patients responding the same to clopidogrel? And as we all know, it's a prodrug. It needs to undergo metabolism to form an active metabolite. And there certainly are a handful of patients that are not responding optimally. And so it's with that in mind that the medications, both prasugrel and ticagrelor, have come along. Now, what do these two drugs have in common? They're both affecting the platelet. They have high degrees of platelet inhibition, and there's not as much variability from patient to patient. So these new antiplatelet agents are ending up with platelets that are essentially less sticky, and that ultimately can be good for the right types of patients.
Could you summarize sort of where the appropriate loading doses are in acute coronary syndromes amongst the different agents?
So when we have these patients and we have someone who you're treating with clopidogrel, there certainly is some variability in the treatment strategies. Some patients are being loaded with 300. In other countries, patients are being loaded with as much as 900. In general, what we recommend is a loading dose of 600 milligrams and then a standard maintenance dose of 75 milligrams. In terms of prasugrel, it's 60 milligrams, then with a 10 milligram dose for maintenance, and then with ticagrelor, 180 for the loading, and then 90 twice a day. So we always do have to remember that doses are different for these different therapies.
So when we see patients coming in with an acute coronary syndrome, why don't we start with the STEMI patient? And also, as we go along, maybe you could highlight differences, the slight differences between the AHA-ACC guidelines and the ESC guidelines.
And I'll just give some examples of how I end up handling these different therapies. If a patient is at particularly high bleeding risk, and so what do I mean by that? These are patients who either had recent active bleeding, they had prior severe bleeding, patients who are already on oral anticoagulants, or patients potentially being treated with thrombolytic therapies. These are patients where a standard clopidogrel pathway would really be the right thing to do. Now, we again have to remember the variability that we discussed earlier. And if a patient is already on clopidogrel and is having a second event, that also gets my attention. But those patients, as I say, there we can use a standard clopidogrel pathway. Now, in other patients, so patients who we don't think have an increased risk of bleeding, and we're not concerned about using a non-generic drug, that's patients where ticagrelor or prasugrel may really be the best option. As I said, the thing about these drugs is they achieve higher degrees of platelet inhibition. And in two large studies, so in Triton TIMI 38 as well as in Plato, these kind of strategies led to a reduction in cardiovascular death and minor stroke as compared to clopidogrel. There was a slight increased risk of bleeding, but overall also a reduction in stent thrombosis and the types of events that we care about when we're treating our cardiovascular patients.
So how do the different guidelines between the U.S. and Europe classify how we should be using prasugrel and ticagrelor in these patients with ACS or for STEMI?
So if we look at the European guidelines first, the way they have approached this is with the new data that we just discussed, so data from Triton TIMI 38 and Plato. What they have said is that if a patient can tolerate these new drugs, then these are preferential. So these are really put at a first-line status, and then clopidogrel is used for patients where these drugs wouldn't be appropriate, a little bit like the example we just talked about with the STEMI patient in front of us. On the other hand, the U.S. guidelines currently give the option of either clopidogrel, prasugrel, or ticagrelor, so putting them on a more even playing field. So those are the nuances and the differences, and I think everyone gets comfortable with their own practice somewhere in between those two guidelines.
Well, what about in patients with unstable angina or NSTEMI? Should we be preloading them with one of these newer agents, or should we wait to see the anatomy? How do you approach them?
So this brings up a very controversial area, and it really is whether or not we should be preloading patients with unstable angina or non-STEMI. And there was a meta-analysis that came out earlier this year suggesting that there was no reduction, at least in terms of mortality, for preloading with dual antiplatelet therapies. Although if you look at this meta-analysis, there was a reduction in ischemic endpoints. So if you are going to preload, then we need to think a little bit about how the trials were designed. And ticagrelor and clopidogrel have been given as preloads. In terms of the Triton study testing prasugrel, there the anatomy needed to be known before prasugrel was actually given. So that ends up determining a little bit about which agent you may want to use in that particular scenario. It also brings up an important point about what happens to patients who undergo medical therapy. So let's say you have someone who comes in with a non-ST elevation MI and you're not going to go to the cath lab, but instead you're going to treat them with medical therapy. Well, in that case, if you look at the data, ticagrelor in the Plato study looked pretty good in these patients. On the other hand, the Trilogy study, which was reported earlier this year, in medically managed patients, prasugrel really didn't have an advantage over clopidogrel. So just another point we have to keep in mind.
What happens if you go to the lab and you decide to switch agents? So you started on ticagrelor and you're going to be switching to clopidogrel after the PCI. How do you handle that?
Well, these are certainly the logistics that we're all thinking about these days because sometimes we have to switch for insurance reasons, sometimes for patient satisfaction. The way I handle it, for example, if a patient has been given ticagrelor, but you're going to switch them to clopidogrel, you're going to want to reload. So reload those patients and then start the maintenance dose therapy. Because the idea is to try to make sure that patients don't have a period of time when they're off drug, especially upfront after their ACS or PCI, a period of time where we're most worried about repeat and recurrent events.
If you're switching, say, from ticagrelor to clopidogrel to reload with a loading dose of clopidogrel, then the maintenance dose of clopidogrel.
Exactly.
So one other thing we should summarize is some of the contraindications or things to be concerned about with the newer agents. So who are the patients we should be concerned about using these agents, or which patients are they contraindicated in?
Well, with many antithrombotic therapies, we have to remember that they're antagonizing the platelet and or the coagulation system. And when we do that, we typically say there's no free lunch. So you're trying to reduce ischemic events, but on the flip side, these agents can lead to a higher risk of bleeding. So particularly with prasugrel, there is a warning about patients with prior stroke or TIA. So prasugrel would not want to be used in those kind of patients. In terms of ticagrelor, there is some dyspnea associated with the medication. I'll note that normally if you keep treating patients, they get through the dyspnea and they do okay, and there's no long-term side effects in terms of pulmonary damage, at least looked through things like pulmonary function testing. But again, that's something that patients will note and we have to pay attention to. Additionally, with ticagrelor, patients who have severe conduction abnormalities, the drug should be avoided. And the other thing that's interesting in the label is that when patients are treated with ticagrelor, they should also be treated with low-dose aspirin. So this is something that was highlighted in the package insert for this medication. So a few nuances with the drugs that we have to think about, certainly when we're trying to balance efficacy and safety and get the right drug to the right patient.
One question I have, which a lot of people have, it's confusing because the mountain of evidence about, or papers about pharmacodynamic testing and platelet testing of all these agents and being able to predict events. When do you use that, or is there a role, and what do the guidelines say now?
On one hand, it makes sense that these medicines work by targeting a certain degree of platelet inhibition. And I think with that in mind, there was enthusiasm around the concept of measuring platelet inhibition. And there's a lot of data suggesting that patients with high platelet reactivity have poor outcomes. What's been more challenging, however, is that we don't have great data to suggest that if we change therapies based on these numbers, so if we get a certain platelet reactivity back and we do something with the therapy, can we actually make our patients live longer and live better? And that's where there's a little bit of a lag in the data. So the way I handle it is typically we're not routinely checking platelet function. And if you look at almost all of the guidelines, that's where the guidelines have fallen out. However, in selected particular patients based either on clinical features or if they've had multiple recurrent events or someone who's had an event while already on antiplatelet therapy, these particular patients may end up benefiting from platelet function testing. But I would say it's still a very evolving field and not something that we're doing routinely.
So to summarize, it sounds like we have the option of either using clopidogrel, ticagrelor, or prasugrel, especially in the STEMI population. In the unstable angina and STEMI population, probably starting with ticagrelor or clopidogrel is the best route. And the Europeans in the STEMI population have said prasugrel or ticagrelor are preferred. And for patients who get switched after their initial catheterization, we need to reload the dose of the second agent. So, for example, ticagrelor to clopidogrel, reload with clopidogrel. And also recognize that in medically managed patients with ACS, which is almost a quarter of the patients, that they should not be taking prasugrel. Is that correct?
That's exactly right. And the way I end up thinking about this, and I know as we talked about in the introduction, there's a lot of data coming at us as clinicians and many decisions that we have to make. The way I think about it is dual antiplatelet therapy has been established as beneficial to our patients. We have clopidogrel as a backdrop, but we now have agents that achieve higher degrees of platelet inhibition. And in the right patients, these really can reduce hard cardiovascular endpoints. So it's exciting to be a cardiologist at a time where we have therapies where we can actually improve people's lives. But with that being said, and we spent some time today talking about the nuances and times where we may not want to use these medications. But again, I think that this is good news for us to have choices and different therapies. And the other idea that's coming up is trying to figure out how long to continue these. But certainly that's another discussion, and we'll look forward to discussing that at some point as well.
Thanks so much for joining us.
Thank you.